Afternoon or good morning to everyone, and thank you for joining today's Journal Club, sponsored by the American Thoracic Society Assembly on Sleep and Respiratory Neurobiology. We will be discussing the recent ATS Workshop Report entitled The Great Controversy of Obstructive Sleep Apnea Treatment for Cardiovascular Risk Benefit, Advancing the Science Through Expert Consensus. I am Dr. Ninotchka Sigua, staff physician at the Rodebush VA Medical Center and Associate Professor of Clinical Medicine at Indiana University. Joining me is my co-moderator, Dr. Serena Xia, an assistant professor at the University of Southern California Keck School of Medicine.
Thank you, Nach, for the introduction. So now I would like to go ahead and introduce our panelists in no particular order. First, we have the four co-chairs of the workshop report. We have Dr. Oren Cohen, Assistant Professor of Medicine at the ATS School of Medicine at Mount Sinai. We have Dr. Vaishnavi Kundel, Associate Professor of Medicine and Sleep Medicine Fellowship Program Director at the ATS School of Medicine at Mount Sinai. We have Dr. Neomi Shah, Associate Dean for Faculty Career Advancement, System Vice Chair for Faculty Affairs in the Department of Medicine, Director, Clinical Strategy and Oversight for Respiratory Institute, and Professor of Medicine at the ATS School of Medicine at Mount Sinai. And we have Dr. Henry Yaggi, Vice Chief of Research for Pulmonary Critical Care and Sleep Medicine, Director of Yale Program in Sleep Medicine, and a Professor of Medicine at Yale School of Medicine. Then we have four invited discussion panelists. We have Dr. Richard Castriotta, Professor of Clinical Medicine at University of Southern California, Keck School of Medicine, and Professor Emeritus at the University of Texas Health Science Center at Houston Medical School, and Dr. Shahrokh Javaheri, Sleep Physician at Bethesda North Hospital, Professor Emeritus of Medicine, Division of Pulmonary Critical Care and Sleep Medicine at the University of Cincinnati, and Adjunct Professor of Medicine, Division of Cardiology at the Ohio State Medical School. We have Dr. Allan Pack, the John McCloud Professor and Assistant Dean and Director of Global Sleep Programs at Perelman School of Medicine, University of Pennsylvania, and the Director of Research Training, Division of Sleep Medicine. And we have Dr. Christopher Schmickl, Assistant Professor of Medicine and the Director of Advanced Care and Electrostimulation for Sleep Apnea Program at University of California, San Diego.
So we will start with a presentation of the workshop report by Dr. Erin Eschbach, a sleep medicine fellow at Yale School of Medicine. During her presentation, we have a few questions prepared for our panelists to address. At the end of our presentation, we will open the discussion for our panelists and audience. Please use the Zoom chat to enter your questions or comments at any time. This session will be recorded and posted on the ATS website, and a recording link will be sent to all the registrants. So without further ado, let's welcome Dr. Eschbach.
Thank you all for joining. I'm sure we're all aware, but we're going to be discussing the article, The Great Controversy of Obstructive Sleep Apnea Treatment for Cardiovascular Risk Benefit, Advancing the Science Through Expert Consensus. I'll start with a very brief discussion outline because we have a lot to talk about. We'll just briefly go over the workshop goals, talk about the limitations of existing studies, a quick overview of different subtypes of obstructive sleep apnea that may have differing responses to CPAP, and then describe research gaps in the literature and new directions for future research. Briefly, the goals of the workshop were to review the current literature and gaps in evidence, to discuss new directions to approach future research with an emphasis on underrepresented groups previously not focused on in the existing literature, and then to review phenotypes of OSA that may predict cardiovascular disease and thus should be applied to clinical and research settings. Very briefly, as I'm sure this group is all quite aware of the existing research, there are four main randomized control trials that studied the effects of CPAP on cardiovascular disease. We have one study that was studying the effects of primary prevention of CPAP on cardiovascular disease, published in JAMA. And then we have three studies, RICADSA, Isaac, and the SAVE trial that studied the effects of CPAP for secondary prevention of cardiovascular disease in primarily mildly sleepy or non-sleepy patients with sleep apnea. And most of these were studying composite cardiovascular disease events and did not show any benefit of CPAP on cardiovascular disease. However, there's obviously things that we need to consider here. The fact that most of these studies had a very low adherence to therapy, which biases the treatment effect to the null. The fact that a lot of these patients were already on medications for secondary prevention for cardiovascular disease, such as beta blockers or statins, and the thought that PAP, in addition to these therapies, may not have any extra benefit. Importantly, the lack of generalizability to our sleep clinic patients, the fact that sleepy patients in particularly were excluded, and the fact that there was a lack of diverse patient populations and a specifically very low amount of women in these studies. There's a limitation that they did study composite cardiac outcomes, meaning all of cardiac events in one rather than treatment different cardiac diseases. And the fact that we didn't consider OSA phenotypes or endotypes when studying these in particular. So very briefly, obviously we all know that AHI is not the end-all be-all for sleep apnea. So just getting into a little bit more of this heterogeneity, there are wide variations in the ventilatory, hypoxic, and arousal burdens for people with OSA. There are variations in the pulse rate response, the respiratory event duration, and then the phase in which sleep apnea is most prevalent. And there have been some cohort studies and secondary analyses of randomized control trials that have shown that these things in particular may go on to predict cardiovascular disease outcomes or response to PAP in certain groups. Hypoxic burden being one of them. High hypoxic burden has been associated with an increased risk of cardiovascular disease and death. And several groups, including Dr. Zinchuk, Dr. Panilla, have noted that those who have, with high hypoxic burden, who have use of PAP have been found to have a reduced incidence of incident cardiovascular disease. Dr. Panilla, this was a post hoc analysis of the ISAC study in particular. We also have the delta heart rate. And we know that subjects with an elevated heart rate response have a greater response to CPAP therapy compared to those with a normal heart rate response. This has also been shown in many studies as well. Next, the respiratory event duration. Interestingly, this is by Dr. Cohen, one of obviously the co-chairs of this event, showed that short respiratory event duration may be associated with a higher risk of cardiovascular disease, and that CPAP is actually protective in those with a short event duration. And when they stratified, this is the ISAC study again, when they stratified patients by a short event duration or a long event duration, and then those who had a low ASCVD risk score versus a high ASCVD risk score, they found differing outcomes. And actually those with a high ASCVD risk score and a long event duration, subgroup 3, they actually found that CPAP in this group was associated with worse outcomes. More to come on that later.
Okay, so we're going to take a brief pause here and we're going to ask the first question to Dr. Cohen and Dr. Javaheri. In your clinical practice, do you incorporate these physiologic parameters to prescribe PAP therapy? And are they practical to implement? And does your sleep lab routinely measure these physiologic parameters? And we can have Dr. Cohen to speak first.
Thank you very much. And nicely summarized, Erin. So these, I don't think these clinical parameters have not been validated sufficiently yet. And while our lab collects event duration, it's a standard value, and specifically in our lab, it's not something that we changed based on any results of any study. I don't know of many physicians who are actually looking at that parameter and deciding, to give or not give PAP therapy based on that. And then similarly, the we have T90 and other measures of global hypoxemia, but we're not looking at the OSA-specific hypoxic burden or heart rate variability as yet. I think that there's a lot more work that needs to be done to validate these before we start making evidence-based decisions or start changing our guidelines for how we practice. Dr. Javaheri?
No, yes, I do agree with you and concur with you all that you said. We do not use any of these. Of course, we really need randomized controlled trials based on some of these issues that have been discussed to see if this really comes out to be correct or not. Some of these things do make sense to me. For example, the heart rate delta, the higher that number, that suggests to me that following the apneas or hypopneas and accumulation of hypoxia and CO2 can be increasing sympathetic activity more, such that those individuals have a higher heart rate, and the increased sympathetic activity, of course, has its own cardiovascular issues. I don't know if you can maybe explain to me, why do you think the shorter events which are associated with less hypoxia, less hypercapnia, have actually more impact in terms of incident cardiovascular disease?
So first of all, I'll say that, I think the data for heart rate even is sort of split, right? And we're going to see a U-shaped curve for a lot of these things. These are all going to be very complex phenotypes. So the ability for your heart rate to modulate, or the lack of ability for your heart rate to modulate, is also going to be tied into the health of your overall cardiovascular system. And so I think that one of the issues that we're finding is we can pick and choose a lot of different metrics, but we don't know if those metrics are causal, or if there's any mechanistic pathway, or if they're just associated with other components of somebody's overall health that shows us something about their underlying cardiovascular disease risk. And I think that the important piece to pick apart is, where can CPAP, or where can treatment of obstructive sleep apnea, say more broadly, help to intervene? The thought for short event duration is that it's some marker of arousability or high arousal threshold. We actually didn't see a difference between the hypoxic burden. This is unpublished data, but Ali Azerbaijan shared his hypoxic burden metrics from ISAC with us. And we didn't see that there was a different hypoxic burden between those with short or long OSA event duration. So what I surmise from that is that even though these are shorter events, maybe the hypoxic dips are on average deeper. We didn't see a difference overall between those two. So maybe there's something about the shape of the desaturation curve that's going to be important. I just think we don't know. And right now we're trying to isolate mechanistically specific individual variables, where I don't want to give away too much, but I think the future is going to be more looking at raw data and using AI and machine learning to try and figure out how we can get a better picture of composite variables that takes a complex system and tries to summarize that and can spit out something like a disease risk profile for cardiovascular disease risk and for treatment.
Thank you, Dr. Cohen, Dr. Javaheri. We're going to have Oren continue.
Well, I am, from a physiological point of view, this is very surprising to me, because look, we have placed balloons in the esophagus of patients with sleep apnea. The longer the event, the more hypoxia, the more hypercapnia, the more negative intrathoracic pressure changes, and collectively these could be associated physiologically with more incident cardiovascular disease. So I'm, of course, still surprised at Dr. Cohen's study, but I don't physiologically quite understand it, because again, based on all I know and what I have done research, that appears to be the opposite of what I know and what I believe physiologically. But as he says, these needs to be figured out in more systematic studies, and I agree with that.
I just want to quickly add that.
Yes, go ahead, Vaishnavi.
I just want to quickly add that there was another study published in the Blue Journal in 2019 that corroborated this, where short event duration was associated with higher mortality. So, this is not in isolation, the findings that Dr. Cohen found. So this has been corroborated in another study. I think, I agree with everything that Oren said, that I think understanding the mechanisms is a separate issue, but yeah, I just wanted to point that out.
No, right. Yeah, that's correct. But again, physiologically, there is a paradox here.
Yeah, and I think if I can just chime in, I know Richard has his hand up, but I think I just wanted to just make a quick point, if I may. So first of all, Shahrokh, I met your son at WashU 2 days ago. So it's great to meet with him. So I'm just sort of putting that out there. And then to your point, exactly, right? I think the reason we are in this current situation is that a lot of the physiologic and epidemiological signals do not necessarily match with the patient outcomes. And I think to me, that's a place where we do have to have an open mind and say, well, okay, this is completely contradictory to what we have learned over the last 20 years. But what we have learned over the last 20 years is also not directly impacting patient care, meaning if all of this was bad, treating sleep apnea should improve outcomes. So I appreciate your comment very much. And I think this is a great point for us to discuss, but I don't think this paper, this webinar is not about Oren's paper. If you want, we are happy to come back and dissect that paper further. But my recommendation to the group would be to move on so we can continue the webinar.
I just wanted to briefly say that there is a physiologic explanation or pathophysiological explanation that if you've got heightened autonomic nervous system response resulting in the more dramatic heart rate changes and shorter duration of action, the heightened autonomic nervous system response may result in a higher systemic blood pressure during sleep. And our studies have indicated that it is the blood pressure during sleep that correlates with cardiovascular events more than anything else. So that would explain these findings. We just have to remember that we can't get ourselves hung up on isolated individual parameters because everything is all interconnected and it may be more complex than that. But there is a logical explanation.
Great, thank you. I'm gonna move on to more symptom subtypes. So as we discussed earlier, previous trials studied mostly mildly sleepy or non-sleepy adults. However, we know clustering people based on certain symptoms that they have yields differing results. And so this is a study that was published in Chest in 2021. And this study studied Isaac, SAVE, Sleep Heart Health Study, and basically clustered the patients based on their symptom subtypes. So unfortunately, the colors are different for excessively sleepy in this, but excessively sleepy is in the blue here, and then it is in the green here. And you can see the hazard ratio for those who are excessively sleepy is much higher for cardiovascular mortality compared to other symptom subtypes. It's also those with excessive sleepiness have also been found to have higher rates of inflammatory biomarkers such as CRP. So also thinking that maybe these people have a higher inflammatory subtype of sleep apnea, which is pretty interesting. Then getting into some demographic considerations. So timing of therapy, the age in which we start therapy. So there's less evidence to know if starting people younger on CPAP therapy for basically the prevention of endothelial dysregulation or inflammatory damage may yield benefit. However, we know larger and longer trials may be costly and difficult to perform. The one primary prevention trial that we have thus far, as I mentioned, has been negative. And then other comorbid sleep disorders have also not truly been considered in other studies thus far. And we also know that people who have short sleep duration, sleep irregularity, insomnia have also been found to have worse outcomes. And so the composite OSA and insomnia or COMISA is something that hasn't really been encountered thus far. So future RCTs should potentially not just focus on the intervention of PAP, but the intervention of more holistic interventions that treat the sleep health as a whole. Obviously, there are important sex differences in OSA. Women are more likely to have a lower arousal threshold, less airway collapsibility, and then shorter respiratory event duration, which, as we discussed, may be associated with worse outcomes. They're more likely to have coexisting insomnia, and then more likely to have a higher risk of cardiovascular disease. Unfortunately, the existing studies have just 20% of studied women in randomized controlled trials. Similarly discounted in previous studies are minoritized groups. Compared to white counterparts, we know that racially minoritized groups have a higher prevalence of sleep apnea and cardiovascular disease. There's also an underdiagnosis of sleep apnea in this group and lower PAP treatment adherence. And this may be rooted in preventable and multifactorial social factors. So racism and discrimination, difficulty getting access to healthcare, people who may be more likely to have limited sleep opportunities or more likely to partake in shift work.
So we'll just take a quick pause here for a couple of minutes, okay? So we can keep going with the workshop report and the discussion. But I want to ask this question to Dr. Shah and Dr. Castriotta. So what do you think should our priority be? Symptom subtype, physiologic parameters. How do we incorporate all these, when currently insurance only looks at the AHI for treatment? How do we move forward with these? Go ahead, Dr. Castriotta, if you want to start.
I think physiologic parameters are objective and more robust at distinguishing phenotypes and endotypes, while symptoms are subjective and often misleading. So a lot of people will have an Epworth score of 0 and you walk into the examining room and they're sound asleep. And people tend to underestimate their degree of sleepiness because they equate that with laziness. People tend to exaggerate their lack of sleep because that's somehow macho to brag about not sleeping. So any parameters that include length of sleep really have to be verified with actigraphy or some other system, not be subjective. I think the physiologic parameters that we need to look at include many of the things that we just saw that we haven't been looking at. And that's hypoxic burden. And here, the oxygen saturation, not just hypoxemia below 90% or 88%, but below 85%. It may be, you have to be really hypoxic to bring about these cardiovascular events. The sleep blood pressure has been totally ignored. And we really, as I said, our studies and those of Ramon Armida in Spain have shown that all of the cardiovascular events are really mediated through the sleep blood pressure. The high sleep blood pressure is the key. The pulse rate response is very important. Event duration, REM apnea hypopnea index, again, has been underestimated. There are good studies that show that if you just have sleep apnea during REM sleep, there are consequences, including objective daytime sleepiness and cardiovascular events more so. And sometimes this doesn't correlate with insurance payments. And then the subtypes of sleep disordered breathing, such as hypopnea dominant sleep disordered breathing, and especially prevalent in the morbidly obese that have an apnea index of 3, but apnea hypopnea index of 80. And somehow or other, these people that have hypopneas without apneas have a pathophysiologic difference. There's something different about their sleep apnea. And I suspect the treatment of that may be different as well. Postural differences, supine, we always talk about supine related obstructive sleep apnea. There have been studies published that show that there are some people that have right lateral predominant or prone or left lateral predominant sleep apnea. And these again may point to a different pathophysiology and different source of treatment. The ventilatory burden and the arousal burden. So these are all parameters I think that we need to take into account in trying to put together a reasonable approach to treatment that's individualized to phenotype. We don't have enough evidence right now to distinguish endotypes, but we should be able to distinguish phenotypes and select our treatment accordingly.
Thank you, Dr. Shah.
Yeah, first of all, thank you, Nach, for inviting us for this seminar. I really appreciate it. I also want to give a huge shout out to Oren for lifting the heavy work of this workshop, which is a lot of work. And then, of course, my mentor, Clara Yaggi, and my colleague, Vaishnavi, for her help, and Erin, who we trained. And I'm so happy that she's at Yale presenting this. So I just wanted to take a moment to do that. I think what I will answer this is, how do we prioritize symptom subtype over physiologic parameters? My answer would be, we shouldn't prioritize. I think we need to include both. And so I would urge us to think about, why are patients symptomatic? What is driving them to be symptomatic? Is it OSA, or is it other things that, are there other things they do in their lives that make people symptomatic? So if you have a sleepy patient, my task is it the OSA, or is it the fact that they're sleeping 4.5 hours? And no matter how much I subtype and endotype OSA, I'm not going to fix that, right? So as a clinician, as a physician scientist, I'm constantly sort of thinking about, why pick one over the other, which is sort of comes back to why select a metric or a cluster of metrics. So that's one. And then how do you suggest we implement the use of phenotypes and endotypes? I think that this is what big data and machine learning and AI can help us. And I don't think we need to pick one or the other. I think they're both important, and there are hidden features that we may not fully understand that predict outcomes, or unexpected features that we may not fully capture with a human eye on a PSG, or, just in our traditional statistical modeling. So I think my answer would be, we need to push the field of sleep research harder, so we can provide a data-driven approach to this, so that the insurance companies don't have a choice but to acknowledge that these are the metrics that are critical in decision-making, and they will move away from AHI. So my answer would be, for number one, we should not prioritize. We should include everything we have using big data. And then for second, we need a data-driven tool that can be implemented in a clinical setting.
Thanks, Dr. Shah. I'll next move on to the theme that there actually may be, in some cohorts, a potential for CPAP to cause harm rather than benefit. And this is going into some of Dr. Shah's earlier work, where she found that apnea-hypopnea index is actually associated with a lower troponin level during an acute MI. And we know physiologically that patients with OSA actually have augmented coronary collaterals, going into the thought that maybe people who have obstructive sleep apnea and recurrent hypoxia may have a benefit of ischemic preconditioning. And then going back to Dr. Cohen's work and some work in the Ricadza cohort by Dr. Yüksel Peker, that PAP may actually result in some harm. So Dr. Peker found that there's an increase in angiopoietin-2, which is a vascular growth factor released from pulmonary endothelial cells in response to lung injury, in response to higher levels of PAP. And then Dr. Cohen's group, as I mentioned earlier, found that those who had a higher ASCVD risk score and were placed on PAP had a lower probability of survival. Again, looking at this subgroup 3 here.
We're going to take a quick pause and then direct this question to Dr. Kundel and Dr. Schmickl. Do you discuss these potential adverse effects with your patients? And do you take these into consideration when prescribing PAP therapy for patients with CAD and ischemic heart disease? Dr. Kundel, if you want to start.
Sure. Again, thank you guys so much for holding this webinar. So I guess I want to start by saying that I've certainly emphasized strongly to my patients that based on all the data and research, we don't know that we don't think there's a cardiovascular benefit in treating them with CPAP. So our focus in clinic is primarily on symptoms, whether they have mild, moderate, or severe sleep apnea. So I really make that very clear up front, letting them know that if they're even remotely symptomatic, even a trial of therapy would be helpful. And then, I really make it a point to explain all the options of treatment, not just CPAP, especially now with the advent of GLP-1s. So I really go through the range of treatment options. With regard to me considering, if it changes my PAP prescribing practices, these data, I would say that I really especially in patients with coronary artery disease and MI. I certainly take that into consideration where I think Dr. Yellick, who just gave us grand rounds earlier this week, her data showed that at higher CPAP pressures, there was elevated levels of angiopoietin 2, which is a vascular inflammatory marker. So I try to avoid, really higher PAP pressures, especially in that population. I try to focus on more the use of nasal masks versus full face masks, because we know that full face masks require higher pressures to be therapeutic. So yeah, that's kind of how I've started incorporating this in my practice, really focusing more on symptoms, making it very clear to patients that at this point we don't really know or think there's a cardiovascular benefit with CPAP, given the limitations in the data. And then try to, really focus on optimizing their sleep apnea with a lower range of pressures.
Yeah, maybe let me just add a couple of thoughts to that. And first of all, thank you so much for setting up this workshop, which is really interesting. Great presentation, Erin, and fantastic work on putting together this ATS statement, I think, which is really critical for the field. I think for me, these data about angiopoietin 2, those are intriguing and interesting, as they might provide an explanation for why do we see these net neutral trials potentially. But I don't think they're ready yet for prime time. I mean, in the sense that, I don't think it has been validated enough that I really start worrying right now about, warning patients that you should stay away from this. Obviously it's a very, that maybe in a few years we have to tell patients that maybe there was some harm that we didn't realize or so, but I think right now that's usually not something that, is part of my discussions. I think in clinical practice, usually the bigger challenge I face is that, the patients who are not symptomatic, who then come to me and say should I be treated? And a lot of them do come then with that expectation that it's going to help improve their cardiovascular health. And so, similar what Dr. Kundel was saying, we usually have a discussion about how the evidence is mixed. But for me, it's more a discussion that maybe there's some benefit or maybe there's no benefit. I usually don't go into okay, I'm really worried about that we're creating some major harm. And I think part of this is also realizing that for a given patient, we never really know what's going to happen. Everything we do in our treatment is always based on average effects that we see in clinical trials, and even personalized medicine, we're just trying to get to smaller and smaller subgroups. And so until I see really validated consistently that, there's some average effect that makes me think that would apply to my patient, I don't think I would really overemphasize it. But overall, it does make me more careful. I think there's always risks and benefits, so I'm overall more careful. I'm not pushing CPAP for patients who are not symptomatic.
Thank you. Next, the workshop panel went into considerations on where to focus future research on, and they had these 4 kind of groups and separated it out as such, so I'll do the same. First is the fact that we should be studying, as you all mentioned, endophenotypes and expanding demographics. So we need to study specifically the different phenotypes as we discussed, and the excessively sleepy symptomatic group as well. Evaluate the effects of the coexisting sleep disorders, as I mentioned, and then discern which subgroups PAP may be causing harm in, as that may be resulting in our net neutral effects seen in our RCTs. And then very importantly, improve generalizability. And so it means including racially minoritized groups and improving the amount of women that we are incorporating into these trials. They also mentioned that we would like to evaluate the proper timing of PAP implementation, if we should be focusing on primary or secondary prevention, and then improve data on non-PAP interventions and cardiovascular outcomes. So I know this is a focus on, mostly we've been talking about PAP, but as Dr. Castriotta mentioned, there are some data about, this is actually on nightly blood pressure or mean arterial blood pressure at night in the MAD cohort. And this study actually found that in subjects who are on an MAD, a mandibular advanced device, rather than CPAP, there was an improvement in overnight mean arterial blood pressure variation. So there is positive data here that maybe we need to focus more on. This is just the hazard ratio, sorry. And then we need to utilize new statistical techniques to move away from the study of composite cardiovascular risk. We know that different cardiovascular diseases, so if it's tachyarrhythmia, hypertension, heart failure, have different physiologic nituses. And so maybe different manifestations of cardiovascular disease may affect one disease versus another, though this would be very difficult because we would need a very large trial. So utilizing new trial techniques would be beneficial here, as well as machine learning and AI. Potentially look into biomarkers like angiopoietin-2, as we discussed. And then lastly, overall come up with some collaborative research network. So also have some data sharing, availability of everyone's research to look at all of this together to enlarge the study population that we have access to, and then shift research from the cardiology clinic to the sleep clinic, where we tend to focus more on patient symptoms rather than just cardiovascular disease itself.
So thank you, Dr. Ashback, for summarizing, the highlights of the workshop report. I know two of our panelists had wanted to share a few of their slides. So we'll start off with Dr. Pack. I'm going to pull up Dr. Pack's slide. And then Dr. Pack, I think you're on.
Yeah, thank you very much for inviting me to do this. So, I wasn't an attendee at the workshop, so it was interesting to read this report, and thank you very much for inviting me to discuss it. I think the report has important strengths. I mean, it really does a very good job of laying out the heterogeneity. We've had an excellent presentation about that, and it really lays out very clearly the different aspects, the symptom subtypes, the physiology, and so on. I also strongly agree. One of the recommendations, which is earlier in the report, doesn't quite make it to the end, is that we need a cohort of patients where we're following them over time, we're looking at outcomes, we're getting biomarker data, and so on. And that, because when you look at all of this literature, people come up with new things, and then they go to the sleep heart health study to see how well it works. And the sleep heart health study is not particularly representative, but isn't representative of the patients we see clinically. And if we have that type of cohort, we can access resources like TopMed, which provide processing of the samples for whole genome sequencing and so on. Without that cohort, it's hard to take access of that. And I strongly agree with expanding the scope of the National Sleep Research Resource. Talk about international and so on. So I think that the report has enormous strengths. Could you back up one slide? It also has weaknesses. I don't believe this report is particularly balanced. I think it does not. It's very heavily focused on the future. It's going to really be RCTs. And I think it does not address really the limitations of RCTs. I'll explain in a minute. And it doesn't give, it talks about it, but it doesn't give equal attention to the use of observational studies with causal inference techniques, and what the FDA is developing, the use of real world evidence and strategies to do that. So other fields are moving on in different directions. We seem to be a little stuck. Next slide. What are the limitations? This is an article that was quite old now, 2017. It was written by Dr. Lauer, who at that time was Deputy Director of NIH. And he laid out in a review article a perspective in a cardiology journal about limitations of RCTs. What he said is the following: they're way too expensive. I understand as a director of NIH, you're worried about that money you're putting into this. They're too bureaucratic. They take too long. And I've got an example here from the Advent trial. The first person in the Advent trial was recruited in September 22, 2010. Recruitment finished in 2021, 11 years later. 11 years. By the time the publication came out, it was 13.5 years. So if we're going to go down the road of randomized trials, is the only way we're going to collect evidence. We're going to have to be like one of these Social Security people that look like they live to over 300, because it takes a very long time. The other challenge you have if you take a long, long time is that things change. You're not in a and again, I mean, when cardiovascular, they're moving all the time. And for example, the CANPAP study, which is the other study that Dr. Bradley led in Canada with his heart failure and CPAP, which preceded Advent. What happened was, in the middle of that trial, beta blockers came in, and beta blockers affected event rate. And the Data Safety Monitoring Board looked at the drop in event rate and said, this trial does not have this trial does not have the power it needs, and terminated the study. We're now in a situation where we're in a rapidly evolving situation. Could you back up one slide? In the impact of GLP-1 agonists. Well, they're going to change the game. And so the game is going to change. There may be other things coming along that's going to change it. And they also pointed out that they often study the wrong people. In our world, as we've heard, we've studied non-sleepy people with poor CPAP adherence. And he advocated for a new approach, and there are other articles that have come out since then talking about that. Next slide. One of the questions, of course, is, will evidence-based groups really recommend only based on RCTs? And from the point of view of the ATS, and I think this is very, very helpful, is the answer is yes. The answer is that evidence-based groups in the ATS are going to give substantial weight to observational studies with causal influence. Next slide. In fact, you should read this report. It came out in 2021. This is another official statement by the American Thoracic Society, and it's entitled Informing Healthcare Decisions with Observational Research Assessing Causal Effect. This is a very, very helpful document, and I would urge everybody who went to that workshop to read this document. Next slide. What they lay out is they describe the strengths and limitations. It's more balanced. They describe the strengths and limitations of both RCTs and observational studies. They describe the basis of the perception by what they quote, some in the medical community that only RCTs provide evidence, and they debunk that notion. It just seems that some in the medical community may be somewhat overrepresented in our own field. And it lays out a clear criteria for the role of observational studies and overall evidence making and making clinical recommendations. Final slide. They actually state quite clearly where observational studies and RCTs should be used. They indicate that in certain situations, the observational studies will replace RCTs because they're low evidence-based RCTs and so on. They're complementary in many situations, and they can be sequential. In other words, you can do a group and a very specialized group of people, and then you can extend it using observational studies. And so I would argue that the failure of this report is it does not give equal weight to RCT approaches and observational studies with causal influence. And both approaches need to be pursued in parallel. And I think if we do that, we'll be able to advance our field. So thank you very much.
Thank you. Dr. Yaggi, you want to comment on that?
I thought that was a very, very thoughtful presentation by Dr. Pack, and I agree with I think the central premise of his argument. And in fact, my primary mentor when I was starting out in research, John Concado, is actually, I think, leading the FDA's effort in observational studies and looking at real world data. I think what led to the waves of these 4 randomized controlled trials was a general consensus in our field going back a decade that observational studies looking at treatment efficacy, and at the time, I think the paper by Marin and colleagues was the first really big example of this, was confounded by a healthy user effect. Those patients who were wearing CPAP are also taking their medications, leading healthier lifestyles, et cetera. And I think this wave of randomized controlled trials tried to get at that. There were a number of observational analyses that we intentionally included in the report, both those studies that looked at and have identified obstructive sleep apnea as a risk factor for cardiovascular disease and stroke. And I think at the time, I think the committee felt that some of the strongest observational analyses that we included were those analyses that were secondary analysis of some of the randomized controlled trials that were post hoc analyses looking at subgroups of hypoxic burden and the delta heart rate response. And the reason we thought these were some of the stronger evidence is because these particular post hoc analyses, in contrast to observational studies looking at treatment efficacy and post hoc analyses looking at CPAP adherence in these trials, were not confounded by the healthy user effect. But I totally agree with Allan's argument. I think as a field, rather than blindly deferring to randomized controlled trials as some gold standard in evidence is not the best path forward, given how, as he eloquently, I think, outlined how hard it is, how expensive these are, how long they take. We really should be asking ourselves what we can learn from all different types of study designs. I think the real advantage of observational studies are enormous sample sizes, particularly with some of these real-world data approaches, and being able to follow these patients over much longer periods of time. But I think these trials are going to need some very rigorous methodologic approaches, such as propensity score matching. And I think what Allan was referring to is targeted trial emulation, which applies some of these newer causal inference analytic approaches to big data, real-world observational studies.
Thank you, Dr. Yaggi. So Dr. Javaheri had wanted to share a few slides too. Dr. Javaheri, if you can keep it within like 4 minutes, so we can ask questions from the audience as well, or our audience can ask questions as well.
Well, as soon as you want me to shut up, you can tell me that, please.
Okay. Thank you.
Let me start by saying that Dr. Pack and myself have written 2 important articles on the pitfalls of the RCTs. But I just want to mention that there are 2 meta-analyses of the RCTs I'm going to review briefly with you. The first one is the Spanish study. Next slide, please. So, because maybe it's all about CPAP adherence and then nothing else really matters a lot. So this is the first study by the Sanchez group from Spain, and they look at the 3 RCTs. Next slide, please. You can move on. Yeah, so these are the 3 studies they looked at, the SAVE, Isaac, and Katsa. And next one, please. So there are a large number of patients here, but what happened was very, very interesting. You can see the demographics here. When they look at the overall outcome, there was really no difference. You can see the hazard ratio here. But there were 961 CPAP, 1,057 so-called good adherence versus 961 poor adherence in these RCTs. And what they found, next one, please. Yeah, you can see the hazard rate. If you look at the overall outcome, intention to treat analysis, there was no difference between CPAP and no CPAP group. But actually, with the CPAP users, there was a reduction in the incident of cardiovascular disease, as shown on the next slide, please. So you can see on treatment analysis adjusted by time varying and baseline confounding factors using a very important Cox model revealed a decreased event risk associated with good CPAP. You can see the hazard ratio 0.69 and the p-value was 0.01. Okay, the second meta-analysis is our own, and this was published in the Blue Journal. Next one, please. So next one, please. Yeah. So this is the one we did. And in this study, we used 2 RCTs that was then SAVE and Ricazza. At that time, the Sanchez was not studied. And 2 more RCTs, which had people with a stroke in it. And what we found was very amazing. Next slide, please. So there were, in these RCTs, there are 1,140 control group, all of them. And there were 943 CPAP users, quote unquote, 4 hours or more in this study. And I was hypothesizing that the good users will have better incident cardiovascular disease protection. But what really was revealing here was very, very interesting. I don't have the mouse to show it to you, but the only outcome that was positive is actually CNS outcomes, not the cardiac outcomes. So there was no significant difference in cardiac outcomes, but important improvement in incidence of stroke, TIA, non-fatal cardiovascular disease, and all the favors were in favor of the stroke and the brain issues. And why is that? That was really very surprising. So this is really independent of the users and not users. I mean, other medications or not, because I was hypothesizing that the users will see benefit across the board, but that was not the case. Only it occurred incidence of stroke and TIA. And why is that? Next one, please. So this is the study we wrote, and Dr. Yaggi is a co-author on that. So after that finding, I was very, very surprised in regard to what I found. And we looked at what is going on with the stroke and OSA. So if you look at this, the sleep heart study and some other studies, in fact, the main consequence of OSA, incident cardiovascular disease, is not the heart issue, is actually a stroke. And why is that? Next one, please. And here is the reason. Ladies and gentlemen, please look at this slide. It's very important. Again, Dr. Yaggi is a co-author on this. So why a stroke is more important than heart? Because during the sleep apnea, we have anesthesia state condition, and the blood flow to the brain is going to be increased because autoregulation is impaired, and the brain is within the skull. So each time the blood pressure is going up at night and the autoregulation is impaired, the brain will swell and there is nowhere to go. In addition, we have this blood pressure that goes up at night. We have AFib that can occur at night as well as, of course, during the day. We have PFO that can promote more embolism, paradoxical, and of course, carotid atherosclerosis. So all of these issues, I think, will promote more stroke, incident stroke, than heart disease. And as Naomi was saying, maybe there is protection with ischemic issue about the heart that she has described. So I think the most important consequence of OSA is really a stroke. And if we go back, next slide, please. Yeah, so if, again, I think Allan and I have talked about this or written about this. If we only can do a study that will be composite of all things, including heart, which could dilute the effect of a stroke, we may need around 24,000 patients. If we were to do a study only on a stroke, primary prevention of a stroke, we're talking about a smaller number of patients. That's it. Thank you.
Thank you. Thank you, Dr. Javaheri. Anybody would want to comment on that? I think I want to ask Dr. Shah, so with what he just quoted about 20,000 patients needing to do RCTs, to show differences. So where do you see machine learning and AI, with like determining who needs treatment and, who would benefit from the treatment?
Yeah, so just responding to Allan's point, I think, Allan, I completely agree with you. I think there's so much data that we already have, and I'm talking not just about epidemiological observational data, I'm talking about the real world. We have electronic health records, and these are patients that already have CPAP, no CPAP. So the RCT push actually comes from an attempt to include opinions across the board of all the contributors to the ATS workshop. It does not represent the opinion of just the co-chairs that are here, because of course we want it to be as inclusive, but I agree with you. I'm not a trialist, and at this point, given the signal for harm, for me, randomizing anybody to CPAP makes me concerned. And I'm not saying there is no place for CPAP. Of course, symptomatic patients, we do use it, but for an endpoint that's a cardiovascular endpoint, always a problem. So my answer to your question, Nach, would be that we need to leverage electronic health records and do, advanced sort of applications of, what some of the work that Oren is working on with Maite Suarez Farinas, who's my collaborator and colleague on emulating trials. So do an RCT using machine learning and AI in existing observational electronic health records. And there are ways that we are developing and pipelines we're creating right now that are actually hopefully going to allow us to do that. And I think that that's the answer to the future. And I completely agree with Allan. And I absolutely love, his vision and how he's so ahead of his time every single time I hear him speak. So I love that. But, I think we need to come together as a group. And I would actually invite the people that are panelists and others to put together an ATS statement as a follow-up to ours on exactly what Allan presented, because I think we do need that. So that would be my answer to your question, Notch.
Yeah, if the audience has any questions, you can put it in the chat, or if our panelists, has any questions for our authors, we would welcome them as well. Because if not, we do have some questions. Serena, you want to ask a question?
Yeah. So are there any treatment algorithm in the works that incorporates physiologic endotype and phenotypes? We can open this up to the panel.
Maybe I can give a comment on that. Recently there was another ATS workshop also chaired by someone from Sinai, Tom Tolbert, who did a fantastic job on endophenotyping for sleep apnea. And so I think, the conclusion of that, which should hopefully soon be published also, was that, there's a lot of exciting work happening, but a lot of this is still like in the, development stage where like we still need more validation studies in order to figure out like how to actually use this in clinical practice, be it like for randomized trials or pragmatic trials or emulated trials or whatnot, before we can really like draw like, solid conclusions on that. The one other comment I wanted to make is that, we often debate so much about like, this cardiovascular benefit for our patients with sleep apnea, but I think it's important to realize that like half of them have like also comorbid obesity, and we now have this tool of GLP-1, GIP agonists where, they have like so many benefits, overall health benefits, where sleep apnea is just one component of that. And so I think, this is something we really should be maybe focusing more on. And there's obviously its own issues, and, we still need more evidence on that. But I think, this is something where, we potentially can help our patients with cardiovascular health, like have a higher confidence there. But let me stop there. Thanks.
Dr. Pack, you had your hand raised.
Yeah, no, I was just going to say thank you very much, Dr. Shah, for these comments. And I agree. I think there is an opportunity here to have a follow-up to this workshop where we're talking about, how could we, the issue of healthy user. I mean, it clearly is an issue, but at the same time, it's a scientific issue. How can we control for that? And I think that, so there are things that we can do to move forward the idea of observational studies with causal inference and deal with some of the challenges that area has. And I think if we did that, we'd have a much more balanced approach.
And I think just a comment from the chat, Naomi had already commented on it, but yes, looking at just other therapies as well, right? So we're always focused on PAP, but how does, surgery, oral appliances, do they all affect like cardiovascular outcomes? I think that's really good to look into too for the future. Any other comments from the group? I think we can probably extend a couple of minutes if that's okay with the panel. But I do have a question on when do we think is the optimal timing for treating sleep apnea? We had a study looking at, primary prevention, right? Or maybe secondary. So do we have to do this all early, or are we all catching our patients late? When do we treat them? What's the best timing for treatment? Dr. Yaggi or Dr. Cohen?
I was just typing, I have to jump off to another meeting. I'm so sorry. I think that's a great question. I think the issue with primary prevention studies is whether it's feasible to do that, given the length of follow-up needed, and but it would be really helpful to have some evidence in that space. And I think one attempt at that was early on in sort of developing the shorter term randomized studies that were done. We're looking at the impact of CPAP in this case on intermediate measures of cardiovascular risk. There was a really well done study, I thought, in the Blue Journal that somehow found sleep apnea patients without other coexisting comorbidities, and I think made a very convincing argument that there may be some real cardiovascular benefit in preventing based on intermediate measures. This was wonderful. Thank you so much.
Thank you. So one comment, go ahead, Dr. Cohen, before we finish.
I was just going to add to that, just extrapolating from the ISAC study, there's maybe potential benefit in those without where this was their first cardiovascular event. But we spoke about this in the workshop, the feasibility of doing a study in young, otherwise healthy people with sleep apnea and treating them for decades just to find an effect is going to be very difficult. And we don't have the numbers. So if you look at, I don't know, the Jupiter trial for rosuvastatin, right, that's like between 15 to 20,000 people where they see a very small benefit. And we're just not going to get those numbers. And so again, going back to that observational data, mining the data that we already have to try and find these effects, I think the problem will be to convince the field to change our guidelines based on that observational data. And I think that's going to be the uphill battle and why the report focused more on adaptive trial design than necessarily observational data, because I don't think everybody's as forward thinking yet.
Well, thank you guys so much for joining this meeting. On behalf of ATS SRN, Nach and I would like to thank our speakers, Dr. Cohen, Dr. Kundel, Dr. Shah, Dr. Yaggi, Dr. Castriotta, Dr. Javaheri, Dr. Pack, and Dr. Schmickl for your insights and perspectives. We also would like to thank Dr. Ashbach for her excellent presentation. Also, a big thank you to all of our listeners who took their time to join us today. I hope everyone enjoyed the session and have a great day.
Thank you, Serena and Nach. Really terrific job moderating this.
Thank you. Bye.
Thank you so much.